The secret that doctors don't tell you about shoulder pain. You wake up in the middle of the night with that stabbing pain in your shoulder. You try to turn over in bed, but any movement feels like punishment. You've taken medication, used ointment, applied compresses, and yet the pain keeps coming back. If this scene sounds familiar, you need to hear what comes next, because the vast majority of people who suffer from shoulder pain are treating the symptom while completely ignoring the cause. And as long as the cause is ignored, the pain will keep returning, each time stronger and more frequent. Why the shoulder is so vulnerable. The shoulder is one of the most complex joints in the human body. It has a range of motion that no other joint possesses, which makes it extraordinarily versatile, but also extraordinarily vulnerable. Every time you lift your arm, reach for something on a high shelf, play a sport, or simply drive, your shoulder is performing an intricate choreography of muscles, tendons, and bursae working in perfect synchrony. When any of these elements fails, pain appears. Remember that this content is informational and does not replace the guidance of a qualified healthcare professional. Always consult a doctor or physiotherapist before starting any treatment. In this content, you will understand which are the main medications used to treat shoulder pain, when each of them is indicated, what the risks of self-medicating are, and most importantly, why true treatment goes far beyond any pill. Because those who understand the mechanism of their pain have a much greater chance of overcoming it for good. But before talking about medications, there is something you need to understand clearly, something that will completely change the way you see the treatment of your pain. And that knowledge begins inside your own joint. What the rotator cuff is and why it matters. The shoulder is formed by three main bones: the humerus, the scapula, and the clavicle. All the dynamic stability of the joint depends on a specific muscle group called the rotator cuff. This name may seem strange at first, but it makes perfect sense when we understand the anatomy. This group is made up of four muscles that insert deeply into the joint, functioning like a sleeve around the head of the humerus. They are responsible for the rotational movements of the shoulder, but their most important function is to stabilize the joint from within. Without a strong and functional rotator cuff, the shoulder loses its internal anchor and becomes vulnerable to overloads and injuries of all kinds. Tendinitis, bursitis, and arthrosis. Understanding each condition. When one of the tendons in this group becomes inflamed, we have tendinitis. When this inflammation is not treated and the tendon begins to undergo cellular degeneration, the condition progresses to tendinopathy, which is more chronic and harder to reverse. In addition to the tendons, the shoulder has structures called bursae, small fluid-filled sacs that act as cushions between the tissues. When these bursae become inflamed, we have bursitis. All of these conditions, tendinitis, tendinopathy, and bursitis, can be significantly improved with rotator cuff strengthening. This is not an isolated opinion. It is what science repeatedly demonstrates in clinical studies around the world. It is worth noting that other conditions, such as degeneration of the joint cartilage, known as arthrosis, and ligament injuries, also respond well to progressive muscle strengthening as part of conservative treatment. But before getting to the definitive solution, it is necessary to understand the role that medications play in this process, and above all, their limitations. What comes next will surprise many people who have been relying on medications for months without achieving lasting results. And the reason is simpler than it seems. The vicious cycle that keeps shoulder pain going. When shoulder pain appears, the natural reaction is to look for a medication to relieve it as quickly as possible. The pill works, the pain decreases, and the person concludes they are cured. They resume their normal activities, perform the repetitive movements that probably contributed to the problem, and within a few days, the pain returns. Sometimes more intense than before. And the cycle begins again, as if the body were sending a message that nobody wants to hear. Why medication only masks the problem? This happens because medications for shoulder pain, in their vast majority, act on the symptom and not on the cause. A painkiller blocks the perception of pain. An anti-inflammatory reduces the inflammatory response of the tissues. A muscle relaxant decreases excessive tension. All of this is useful and has its place in treatment. But none of these mechanisms strengthens a tendon, rebuilds an inflamed bursa, or restores the stability of a weak rotator cuff. The real danger lies in this period of artificial relief. With the pain masked, the person uses the shoulder normally, the still inflamed tissue suffers further damage, and when the effect of the medication wears off, the inflammation is even more established. The pain returns stronger, the person takes more medication, and the cycle perpetuates itself indefinitely. Medication should be a means, not an end. It opens a window of comfort in which real treatment can take place. But what are these medications? And when is each one indicated? The answer depends on a detail that most people are completely unaware of. Analgesics, anti-inflammatories, and muscle relaxants. When shoulder pain appears suddenly, we are facing the acute phase. In this phase, the goal of drug treatment is to reduce inflammation and control pain so that the person can function minimally. The main medications used belong to three categories: analgesics, non-steroidal anti-inflammatory drugs, and muscle relaxants. In clinical practice, there are medications that combine all three effects in a single tablet, widely prescribed by doctors in the treatment of acute shoulder pain. None of these medications should be used without a medical prescription, as the improper use of anti-inflammatories can cause serious gastrointestinal, renal, and cardiovascular problems, especially in people with pre-existing conditions or who regularly use other medications. Ice or heat, when to use each one, when. Alongside medications, the classic question arises: ice or heat? The answer depends on the stage of the pain. For acute pain, with only a few days since onset, ice is more indicated, as it acts as a natural anti-inflammatory and analgesic, reducing swelling and the intensity of the pain. Always apply with the protection of a thin cloth, never directly on the skin. For chronic pain, from the 3rd month onward, or in cases with intense muscular tension, a warm compress is generally more effective as it promotes vasodilation, improves tissue nutrition, and relaxes muscles in spasm. The usual protocol is 15 to 20 minutes per application, at least 3 times a day, for 5 to 7 consecutive days. Using heat on an acute inflammation can intensify the problem, and using ice on chronic muscular pain can increase tissue tension and worsen discomfort. Therefore, correctly identifying the stage of the pain before choosing the compress is essential. And for those who cannot take anti-inflammatories orally, there is an alternative that many people completely underestimate. When the pill is not an option. Topical treatments. Patients who practice intense sports, who have a history of gastritis or ulcers, or who have some kidney problem frequently need to avoid systemic anti-inflammatories. For these cases, topical anti-inflammatories emerge as a valid alternative. Applied directly to the skin over the painful area, whether in gel, cream, ointment, or patch form, they significantly reduce the risk of systemic side effects that pills can cause. Topical diclofenac is a widely used example in musculoskeletal pain. Among topical herbal remedies, arnica deserves special mention for its anti-inflammatory and analgesic properties proven in clinical studies, available in gel or cream, and effective in cases of muscular pain and superficial inflammation. Even though it is used locally, professional guidance is always recommended before use, especially in cases of chronic pain. Turmeric and the treatment of chronic pain. When pain exceeds the 3rd month and enters the chronic phase, the continuous use of conventional anti-inflammatories begins to present more risks than benefits, overloading the stomach, kidneys, and cardiovascular system. It is in this context that turmeric, also known as saffron of the earth, gains scientific prominence. Its active compound, curcumin, acts on multiple points of the inflammatory cascade, inhibiting pro-inflammatory enzymes and molecules in a manner similar to some pharmacological anti-inflammatories, and also possesses antioxidant properties that protect joint tissues from oxidative stress. The great advantage is its safety for prolonged use. When consumed in adequate doses, it does not present the side effects of synthetic anti-inflammatories. Turmeric can be consumed in concentrated curcumin capsules, as a powder seasoning, or in the form of turmeric water taken on an empty stomach in the morning. Adding a pinch of black pepper to the mixture significantly increases the absorption of curcumin by the body, enhancing its anti-inflammatory effects. But all this talk about medications revolves around something that has not yet been revealed. And it is precisely this point that separates people who heal definitively from those who remain in endless cycles of pain and temporary relief. What no pill can do for your shoulder. There is an uncomfortable truth that needs to be stated clearly. No medication in the world is capable of curing shoulder pain caused by tendinitis, bursitis, or rotator cuff weakness on its own. Tendons, when inflamed or degenerated, need two elements to recover: adequate circulation and progressive mechanical stimulation. Mechanical stimulation is therapeutic exercise performed in a controlled and progressive manner. Without this stimulation, tendon tissue does not receive the signal it needs to reorganize its fibers, increase collagen synthesis, and recover its functional structure. No pill is capable of replicating this process. What science says about exercise and surgery? The same applies to the rotator cuff. If the muscles that make up this group are weak, the shoulder remains unstable. The instability continues to overload the tendons and bursae. The tendons and bursae continue to become inflamed, and the pain keeps coming back. Clinical studies published in orthopedics and physiotherapy journals consistently demonstrate that patients with rotator cuff tendinopathy who follow progressive exercise protocols show significantly greater long-term improvement than those who rely exclusively on medication. In some studies, the exercise protocol proved to be as effective as surgical interventions for moderate cases. This does not mean that surgery is never necessary. It means that, for a large proportion of patients, it can be avoided with the correct conservative treatment. Therapeutic exercise is not an optional complement. It is the core of treatment. Medications are valuable allies, especially in the initial phases, but they are not the destination. They are the path that makes the destination accessible, and the exercises that make this real difference are simpler than you might imagine. The exercise that most people have never done. The first fundamental exercise in the treatment of shoulder pain strengthens the serratus anterior muscle, located on the side of the chest. This muscle is one of the most overlooked in shoulder rehabilitation, but its importance is enormous. When it is weak, the scapula moves in an uncontrolled manner during arm movements, a phenomenon called scapular dyskinesis. This instability alters the entire biomechanics of the shoulder, overloading the rotator cuff and directly contributing to tendinitis and bursitis. The exercise is performed in a 4-point support position without bending the elbows. The movement consists of lowering the trunk toward the floor, feeling both scapulae come together, and then pushing the floor away, raising the trunk toward the ceiling. 3 sets of 10 repetitions. For those who cannot support themselves on the floor, the standing variation with a ball pressed against the wall produces a similar effect, with the trunk static and only the shoulder performing the forward and backward movement. Rotation, abduction, and the secret of 5 seconds. The second and third exercises work directly on the rotator cuff, with a resistance band attached at navel height. In external rotation, with the elbow bent at 90 degrees and held close to the body, the movement goes from the navel outward. In internal rotation, the movement is the reverse, from the outside toward the navel. In both cases, the muscular contraction must be held for at least 5 seconds at the end of the movement before returning to the starting position. This isometric contraction time is what ensures the recruitment of the deep stabilizing fibers of the rotator cuff, those responsible for the function of centering the head of the humerus within the joint during arm movements. 3 sets of 8 repetitions for each side in each exercise. The fourth exercise is shoulder abduction with the same band, raising the arm laterally from bottom to top, also with 5 seconds of contraction at the peak of the movement. This exercise recruits especially the supraspinatus muscle, the most frequently affected in rotator cuff tendinitis, and is therefore considered one of the pillars of the rehabilitation protocol for this condition. All of these exercises must be performed without pain. If any of them causes pain during execution, the exercise must be stopped and a physiotherapist consulted to adjust the technique or the load. The correct exercise is the one that strengthens without causing harm. And there is a very common mistake that can sabotage all of this effort. Therapeutic exercise versus repetitive strain. There is a misconception that appears with alarming frequency in people who try to treat shoulder pain on their own. This mistake is confusing therapeutic exercise with repetitive strain. Therapeutic exercise is performed in a controlled, progressive manner, with appropriate loads and under professional guidance. It produces a beneficial mechanical stress on the tissues, which stimulates regeneration, strengthening, and the reorganization of tendon and muscle fibers. This is the type of effort that treats the cause of shoulder pain. Repetitive strain is what happens when you use your shoulder mechanically and excessively in daily activities, whether carrying weight improperly, performing repetitive movements at work, typing with elevated shoulders for hours on end, or sleeping in positions that compress the joint. This type of overload is one of the main causes of tendinitis and bursitis, not the remedy for them. Why tendons need time to heal. The confusion between the two concepts leads to very common problematic situations. The person uses medication to control the pain, feels well, resumes the activities that caused the problem, the shoulder worsens, and they conclude that the treatment did not work. What happened was that the pain relief was used as authorization to overload the joint, rather than as a window of opportunity to treat it with the correct exercise. The correct protocol, from the perspective of evidence-based physiotherapy, is to use the period of lesser pain to perform therapeutic strengthening exercises, reduce or adapt activities that overload the shoulder, and respect the recovery time between exercise sessions. Tendons are tissues with slow metabolism and low vascularization, and they need time to process the exercise stimulus and carry out structural adaptation. Training the shoulder every day without respecting this interval can be just as harmful as not training at all. This process requires patience, but the results are long-lasting because they attack the root of the problem. And there is a silent factor that is worsening the pain of millions of people every day, and almost nobody talks about it. The posture that is destroying your shoulder without you knowing. Long before any diagnosis, a silent process is taking place. It develops over months or years, imperceptible at first, but gradually altering the biomechanics of the shoulder until the pain can no longer be ignored. This process has a familiar name: poor posture. The rounding of the shoulders forward and the forward positioning of the head, patterns extremely common in people who sit for long periods or use their phones a lot, alter the positioning of the scapula and reduce the space through which the rotator cuff tendons must pass during arm movements. This narrow corridor between the head of the humerus and the bone called the acromion is the subacromial space, and when it is reduced due to inadequate posture, the tendons suffer repetitive mechanical friction with each elevation of the arm. This constant friction is one of the main causes of subacromial impingement syndrome, a condition that precedes and aggravates tendinitis. The sleeping positions that worsen shoulder pain. Sleep is another frequently overlooked factor. Many people wake up with their shoulder in worse condition than when they went to bed, having spent hours in positions that compress the inflamed tissues. Sleeping on the painful shoulder is one of the main aggravating factors of tendinitis and bursitis. Sleeping face down forces the shoulder into an extreme rotation that aggravates virtually any condition of that joint. The most recommended position is to sleep on the healthy side, with the painful shoulder facing upward and a pillow between the arms to keep the shoulder in a neutral position, preventing it from falling forward during sleep. Small adaptations like these, made consistently, can have a significant impact on the speed of recovery and the quality of sleep. The good news is that both posture and sleeping habits can be corrected with awareness and small daily adjustments. And when all of this is combined intelligently, the result is exponentially better than any isolated strategy. What you eat may be feeding your inflammation. When talking about shoulder pain treatment, diet rarely enters the conversation. But there is a very real physiological connection between what you eat and the level of inflammation your body maintains systemically. A diet rich in ultra-processed foods, refined sugars, and trans fats raises inflammatory markers in the blood, creating an internal environment that hinders tissue regeneration and intensifies local inflammatory responses. In practical terms, a person with inadequate dietary habits has a more intense and prolonged inflammatory response, even when facing the same tissue damage as a person with a healthy diet. On the other hand, a diet rich in anti-inflammatory foods can significantly support the recovery process. Omega-3, found in abundance in fish such as salmon, sardines, and tuna, is one of the compounds with the greatest scientific evidence for systemic anti-inflammatory action. Red fruits, such as strawberries, blueberries, and raspberries, are rich in antioxidants that combat oxidative stress in joint tissues. Ginger, just like turmeric, possesses active compounds with anti-inflammatory properties well documented in scientific studies and can be easily incorporated into the daily diet. Hydration and the health of your tendons. In addition to diet, adequate hydration is essential for the health of tendons and bursae. Tendons have low vascularization, which already naturally limits their access to nutrients and oxygen. Dehydration further reduces this capacity, making tendon tissue more rigid and vulnerable to mechanical damage. Drinking sufficient water throughout the day does not cure tendinitis on its own, but it creates the most favorable internal environment for healing to occur. When therapeutic exercise, postural control, intelligent use of medications when necessary, and a diet that reduces systemic inflammation are combined, the results are exponentially better than any of these strategies used in isolation. The 4 steps to treating the cause of the pain. We have reached the central point of everything that has been presented. After understanding the anatomy of the shoulder, the role of medications, the potential of herbal remedies, the importance of therapeutic exercises, posture, diet, and sleep, it is time to bring everything together into a clear and practical vision of what truly effective treatment looks like. The first step is always professional evaluation. There is no effective protocol without a correct diagnosis. An orthopedic doctor or physiotherapist will identify exactly which structure is affected, to what degree, and what the contributing factors are to your specific pain. Imaging exams such as ultrasound and MRI may be requested to complement the clinical evaluation and guide treatment planning. The second step is pain control in the acute phase when necessary, using prescribed medications, compressors following the correct protocol, and relative rest from activities that aggravate the pain. This is the moment to use medicinal resources intelligently as temporary support, not as a definitive solution. Exercise, maintenance, and freedom from pain. The third step, and the most important, is active treatment through therapeutic exercises. Strengthening the serratus anterior, the rotator cuff in external and internal rotation, and abduction with a resistance band are the backbone of the treatment that resolves the cause of the pain. These exercises must be performed with adequate progression, respecting the body's limits in each session. The fourth and final step is maintenance. After the pain disappears and shoulder function is restored, it is essential to maintain the exercises as a permanent part of the routine. The conditions that cause the tendinitis and bursitis, such as muscular weakness, poor posture, and repetitive strain, do not disappear on their own. If strengthening is abandoned after improvement, the pain has a high probability of returning at some point in the future. Shoulder pain is not a definitive sentence. With the right knowledge, the right tools, and commitment to the process, it is entirely possible to recover a healthy, functional, and pain-free shoulder. Science has already shown the way. Healthcare professionals are prepared to guide each step, and you now have the complete map to understand what is happening and make conscious decisions about your treatment. The next step is yours.